Hello everyone, this is Dr. Jang. In this video, we will be covering mineral and bone disease. As you can see in this diagram, bone abnormalities, lab changes, and vascular calcification may occur from mineral and bone disease, which can lead to cardiovascular disease, fractures, and increased mortality in patients with kidney disease. This slide shows the objective of this module. What are the chronic kidney disease, mineral and bone disorders? These are systemic disorders of mineral and bone metabolism associated with chronic kidney disease. They are reflected in abnormalities in calcium, phosphorus, parathyroid hormone, fibroblast growth factor 23, and vitamin D metabolism. These derangements result in abnormalities in bone turnover, bone mineralization, bone volume, linear growth, or strength. They may be associated with vascular or other soft tissue calcification. The chart shows the changes of these laboratory values. Vitamin D and calcium decrease, then PTH, FGF23, and phosphorus all increase in BMD. This is a very complex system of interactions. In the green arrow, you see active vitamin D increases both calcium and phosphorus absorption by the intestines, increases calcium deposition in the bone, and increases calcium reabsorption by the kidneys. Vitamin D helps maintain serum calcium levels and bone strength. PTH, shown within the gold arrow, helps maintain serum calcium levels. PTH stimulates the enzyme in the kidney that converts 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D. Increased level of active vitamin D in the intestines means an increase in calcium and phosphorus absorption. PTH increases calcium reabsorption from the bones. This means calcium may come out of the bone and move into the blood. Bone strength may be affected. Within the kidneys, PTH stimulates calcium reabsorption by the tubule and increases phosphorus excretion. PTH helps maintain serum calcium, and for some people, at the expense of the bone. FGF23, shown in the maroon arrow, is thought to control serum phosphorus. Levels may increase as serum phosphorus increases. FGF23 is produced by the bone and may inhibit the enzyme that activates vitamin D. Lower levels of active vitamin D results in a reduction in phosphorus and calcium absorption by the intestines. High levels of serum phosphorus stimulates FGF23 production by the bones. FGF23 is thought to increase phosphorus excretion by the kidneys. Repleting vitamin D levels may help lower PTH levels. In healthy adults, phosphate intake is matched by phosphate excretion in feces and urine, and the flux of phosphate between the skeleton and the extracellular phosphate pool is approximately the same in both directions. In patients with kidney failure, dietary restriction of phosphate is insufficient to compensate for the decrease in renal phosphate excretion, resulting in a positive phosphate balance. In addition, bone is often resorbed more rapidly than it is formed because of abnormal bone remodeling in kidney failure. Together, these abnormalities may confer a predisposition to vascular calcification. Hyperphosphatemia stimulates parathyroid gland to secrete PTH. This decreases reabsorption of phosphorus in the proximal tubules and increases phosphorus excretion in the distal tubules. Hyperphosphatemia leads to precipitation with calcium, leading to vascular calcification and hypocalcemia. Resulting hypocalcemia further stimulating PTH secretion. These all increase cardiovascular risk. Elevated phosphorus concentration is associated with bone diseases. Again, hyperphosphatemia inhibits vitamin D absorption and activation. These all further worsening hypocalcemia by inhibiting intestinal calcium absorption. Increased PTH leads to stimulation of osteoclasts to break down bone and release calcium into the serum. So we want to reduce dietary phosphate intake in patients with severe kidney disease and also use binders to bind gut phosphate. The goal is to reduce serum phosphorus and reduce stimulation of parathyroid gland. What is vitamin D and where do we get it? So vitamin D regulates calcium and phosphorus, and it is used for mineralization of bone. So cholecalciferol is vitamin D3. It's generated in skin when light is absorbed. Ergocalciferol is vitamin D2. It's more of a plant form. Vitamin D2 and vitamin D3 are inactive forms, so they must be converted to active form via liver and kidney. Active vitamin D, also known as calcitriol, helps maintain serum calcium levels by enhancing tubular calcium reabsorption. In the intestines, active vitamin D increases both calcium and phosphorus absorption. Vitamin D increases calcium deposition in the bone. The parathyroid hormone helps maintain serum calcium levels. The parathyroid gland has calcium sensing receptors, and parathyroid hormone levels may increase the response to low serum calcium levels. This hormone stimulates the enzyme in the kidney tubules to increase the active vitamin D level and enhance calcium absorption. PTH may increase calcium reabsorption from the bone. PTH reduces phosphorus reabsorption in the tubule and increases phosphorus excretion by the tubule. As a result, serum phosphorus may be within the normal range. PTH helps maintain serum calcium levels and indirectly help maintain serum phosphorus levels. Thus, patients with CKD and BD may be present even with a normal phosphorus level. FGF23 is thought to control serum phosphorus levels. FGF23 is produced by bone in response to high serum phosphorus levels. It inhibits the activation of vitamin D. Active vitamin D increases phosphorus absorption, and lower levels result in a reduction in intestinal absorption of phosphorus. FGF23 also reduces the reabsorption of phosphorus within the tubule, and more phosphorus is excreted into the urine. Serum phosphorus may be within normal range until CKD is advanced. Serum phosphorus is reduced by the actions of PTH and FGF23. This slide may be intimidating, however, it summarizes entire CKD and BD very well. So first off, we're going to start with progressive kidney disease. And then we are going to focus on impaired phosphate excretion, which leads to phosphate retention. This can increase the calcium and phosphorus products, which can lead to soft tissue calcification. Increased phosphate also leads to hypocalcemia. How do we prevent this? We are going to decrease dietary phosphate intake and/or use phosphate binders. Now, Increase in phosphate will also lead to increased FGF23, which can also lead to decreased production of 1,25-dihydroxyvitamin D3. In order to compensate decreased production of 1,25-dihydroxyvitamin D, we can utilize active vitamin D or vitamin D analogs. Due to decreased vitamin D, it decreases intestinal calcium absorption and phosphorus, which may lead to impaired bone mineralization, leading to osteomalacia or renal osteodystrophy. Combination of hypocalcemia and decreased vitamin D and phosphate retention, meaning increased phosphorus, they all lead to increased PTH production, which means secondary hyperparathyroidism. High PTH levels can influence increased renal calcium reabsorption, increased calcium mobilization from the bone, and decreased renal tubular absorption of phosphate. Increased calcium mobilization from the bone will lead to the bone disease, as you can see on the bottom. The cinacalcet or calcium mimetic agents are utilized to decrease PTH levels.